This episode, I'm chatting to Dr. Prem. Dr. Prem is a cardiothoracic surgeon based in Queensland at the Queensland Children's Hospital. He performs life-saving surgeries on children with CHD and is involved in cardiac initiatives across the state and overseas.
We as surgeons, we have an emotional bond with the child and the family. We think because we've operated on them, there's a bond which can never be broken.
Before we begin, we'd like to acknowledge that we're recording on the traditional country of the Kaurna people of the Adelaide Plains. We pay respects to elders past, present and emerging. We pass that respect to any Aboriginal or Torres Strait Islander listeners. Well, a very warm welcome to you, Dr. Prem. So you're joining us from sunny Queensland?
Yes, it's great here during winter. It's a great time of the year.
Yes, it's not as great down here in Adelaide. It's a little bit colder. And for those listening tonight, Dr. Prem is obviously, I'm assuming you've just finished your rounds, is still in his full scrubs, joining us on the podcast. So we're very grateful for your time, Prem, because we're very much aware of how important the role that you play in the lives of children and families with CHD. And we appreciate you giving up your time.
Oh, my pleasure, sir.
That's great. So what does a typical day look like for you, Prem? Like, I'm sure it isn't textbook by any means, but what's a typical day? Like, as I said, for people listening, you're sitting here in your scrubs. So what did today look like?
You never have a boring day. One thing that's guaranteed in pediatric cardiac surgery, you never get bored. Each day is different and each day is uniquely challenging. Even the surgeries, each patient is unique. Each strategy that we do is unique. So you can't walk in thinking, I'm going to do the same thing that I did yesterday, because that's not going to work. So you need to really think about what you're doing in terms of surgery, what strategies that you're going to use, and how you're going to produce the results that you want to produce. That's what makes it interesting. Again, going back to my training, part of my training was in Edinburgh Royal Infirmary, where I was doing my adult training, and I was offered the job as an adult cardiac surgeon. So one day I walked into the theatre and I said, I'm going to do a set of grafts today. There'll be a set of grafts tomorrow. Another set of grafts on Wednesday. Is this what I want to do for the rest of my life? And I thought, no, this is not what I want to do for the rest of my life. So I thought, no, I'm going back to pediatrics. The thing about pediatrics is every single day is different. Every single operation is different. And you never get bored.
So if we can take a step, okay, so you start your day, there's no typical day. You are going to have a set of unique challenges placed in front of you. So when you walk into the theatre or even pre-op, how many people are involved in this one surgery you're about to perform?
Pediatric cardiac surgery probably is the best and the biggest team game that you can think of. Because even before the child comes to theatre, there are so many people involved in that process happening, right from when a GP sees a child and refers to pediatric cardiologist. So the pediatric cardiologist sees them. They have the echo technicians who do the echocardiogram, and you have the X-ray radiographers who do the X-rays, and then the pediatric cardiologist collates all that information and then comes to a decision as to what the condition is. And then every single child gets discussed in Queensland, which is replicated across the country in Melbourne, Sydney, Perth, and Auckland. They are all referred in an MDT or a multidisciplinary team where pretty much all the cardiologists of the state and all the cardiac surgeons of the state, the anesthetist, the intensivist, and the radiologist sit there, look at all this information and say, yeah, that's right. That is the best way of going forwards for this child. And then the family gets contacted by the cardiologist. Then we get involved. We bring them into the outpatient clinic. We talk them through the whole surgical procedures, the risks involved in what we do, and the advantages of what we do, and what happens if we don't do what we plan to do. And then they have all the preoperative investigation done so they're fit for surgery, like cross-matching for blood transfusion if required, taking blood tests to make sure all the liver function, the renal function, and the lung functions are good. And then when they come to theatre, you have the pediatric cardiac anesthetist and the pediatric cardiac anesthetic tech who look after the child when we are operating, make sure they're comfortable, they don't feel any pain, and they are monitored for all the hemodynamic changes that we produce. Then we have this crop team who helps us with the operation, making sure we get the right instruments and the right sutures. And we have the perfusionists who actually run the heart-lung bypass machine for the duration of the open heart surgery that we do. They actually take over the function of the heart and the lung and the machine actually does the function of the heart and the lungs and makes sure the rest of the organs are working well. And from surgical perspective, we have the surgeon and a trainee surgeon who gives us a hand, which is a two-way street. They help us with the surgery. At the same time, we train them so that they can go on to become a pediatric cardiac surgeon. Once that is done, then they're safely transferred back to the intensive care unit, where you have a one-on-one nurses looking after the child during the acute phase of recovery. You have the pediatric intensive care consultant doctor and pediatric intensive care trainees. You have the physiotherapist, occupational therapist, then you have the radiographers and radiologist before the patient is well enough to step down to the ward. Then you have the nursing team in the ward and the cardiology team in the ward who look after the child, make sure they all get better before they're ready to go home. So every single component of these has to be in place and work perfectly well for a surgery to go well, for the child to go back to the family after their cardiac condition has been addressed.
It's quite phenomenal, Prem, even just hearing you rattle that off. Like, this is a day for you, isn't it? It's a day for you to be in conversation, like you said, in that preoperative, or like you said, it's lovely to hear how closely you guys all work together, especially from cardiology right through to obviously even talking about whether or not the surgery is going to, and when it's going to happen. So that multidisciplinary team, that's absolutely huge. So for people who are new on this journey, so I've been through this myself personally. So as you're saying it, Prem, I'm tapping into that moment at the Royal Children's Hospital, and I can see that team in front of me. It is phenomenal, but it's also too quite overwhelming. So is there any advice that you would share, especially with some of our listeners that maybe, are new on this heart journey? They've had a diagnosis for their child, they're waiting for surgery. Is there something you recommend to families to help them sort of process those next steps?
Yeah, a few things. Children having born with congenital heart disease is daunting. It's not something that you would want anybody to go through, but it is daunting. But once you have a condition, that's the reality of what we do. It's absolutely fine to be stressed. It's normal to be stressed. It's okay to be stressed. There are enough support mechanisms in place, not necessarily all medical. There are lots of non-medical support mechanisms. There are support groups. Heart Kids, for example, it's a very good support group, and they have people who have gone through the same journey before them. So I would say, please reach out to these support groups. I would say, by all means, Google, but take that with a pinch of salt. Not everything that you read in Google is the norm, because most of the time you get to see extreme views. So be more guided by what your health professionals tell you, because they put things in context and they put things which is specific for you, which makes more sense because they are the experts. But does not mean that you can't Google or you shouldn't Google. Google by all means, but take that with a pinch of salt, take that in context. And reach out to the support groups. They make a big difference. And ask any questions that you want to ask of the health professionals. They're there to help you. And sometimes we run the risk, which includes me, I'm guilty of it sometimes. We start rattling off technical words and technical jargon. Don't be put off. Just stop them and say, can you explain to me in simple terms? It's not that they don't want to explain to you in simple terms. Sometimes we just get carried away. So it's always a good thing to say, hang on a minute, I don't understand this. Can you explain to me in simple words? And the other thing that's useful is before you meet a health.
Sorry, I don't want to cut you off at all, but I think that's such powerful advice from you, Prem, is exactly that. When we are thrust into this, and it's like learning a new language, the language that's coming back from the surgical team or the medical team. There, lots of terminology and they're big words that are being used that, one of the things that I know that I always refer to is just hearing the word heart failure. You just about think that heart failure means you're going to fall down and have a heart attack there on the spot.
Yes.
But it doesn't. But I think that's just great to hear that from you, to say it's okay to actually just stop and say, sorry, Prem, or sorry, whoever it is, can you just say that for me again, or could you break it down into really simple terms?
Yep. The other thing I would say is we all, me included, we have been, all of us are human. We have our own medical consultation and things like that. We think we'll remember everything when we meet our medical professional and ask all the questions, and you tend to forget. And as soon as you leave the room, everything comes flooding back. So my advice would be write it down or note it in your phone. And then usually most of us tend to ask the questions. Is there anything else you want to ask us? Go through the list. That way you know for sure you asked all the questions and you're not left the room thinking, oops, I forgot to ask this. Oh no, how am I going to go back and ask this again?
Yeah, but it's wonderful advice because, like you said, when you're in the moment, it's quite overwhelming. There's a lot of emotions, a lot of adrenaline going on. And so, like you said, if you take that moment in writing those questions, the team are really keen to answer them for you.
Yep.
So, Prem, you've just obviously stepped us through. No day is the same. Every surgery is unique. There's no Groundhog Day clearly in Prem's world or a lot of your, colleagues' worlds. So can you step us through what are the lists of sort of surgeries that you perform?
Look, we're a small group of professionals in this country. We are 11 of us here in Australia now. So we've got 2 in Queensland, 3 in Sydney, 4 in Melbourne, and 2 in Perth. We work closely as a team. We know each other very well. We work closely as a team, and each state is able to do the whole spectrum of pediatric cardiac surgery, except transplant, which is right now performed in Melbourne.
Okay.
The common operations that we do are what we call as the septal defects, or holes in the heart. The common hole in the heart is what we call as a ventricular septal defect, or the hole between the 2 pumping chambers of the heart. That's probably the commonest operation we do. The other common operations we do are holes in the upper chambers of the heart, or the collecting chambers of the heart, called the atrial septal defect. And then the next common one is the blue baby condition, or the tetralogy of Fallot, which is where there's a hole between the 2 pumping chambers of the heart and the way out to the lungs are narrow. And the other common condition is AVSD, or atrioventricular septal defect. Big word. All that it means is there's a big hole right in the middle of all the chambers of the heart, and the valves are not made properly. And then we have newborn children who need surgery near the time of pretty much soon after birth, like transposition of great arteries, where the big arteries are connected back to front. And we have other complex ones like hypoplastic left heart, where some of the chambers of the heart is not formed properly. So they need to go through various stage surgeries to get them to where we want them to be. But the common ones are holes in the heart and, as I said, tetralogy of Fallot and the AVSDs.
Yeah, I love the fact that you've broken it down very simply. But yeah, the majority of us obviously listening, ASD, VSD, TOF, AVSD, the list goes on. So, and when you're operating on these newborns and young children, can you put into perspective the size of the heart that you're operating on?
The common reference we make is the size of your heart is size of your clenched fist. So in an adult, your clenched fist is approximately size of your heart. So if you're looking at a newborn baby, size of the newborn baby will be size of the baby's clenched fist.
So that's phenomenal.
So if you have to put it to perspective, in a newborn child who's about 3 kilos, it'll be size of a strawberry.
That's phenomenal, Prem. And so you're actually going in and you're repairing a hole on the insides of a strawberry, or creating valves, which I'm sure are the size of, what?
Yeah, but we do have an unfair advantage. We wear magnifying loops, so everything gets magnified by 3.5 to 4 times. So we do cheat a little bit.
I love the fact that you think that's an advantage. That's quite intense. That's quite intense, Prem. And so you talked about before, you've got this massive team, no day's the same, massive team. And obviously, you mentioned it before, there's the heart-lung bypass machine. So for those listening, can you take us through that? Because you said that it actually then performs the job of the heart and lungs while you're operating. So can you talk us through what's actually happening in that machine and who's actually taking care of that?
So, to do heart surgery, especially, things like holes in the heart, we have to open the chambers of the heart. Now, we can't do that unless we can have some way of supporting the heart so that we have a bloodless field. If you open a heart, if it's full of blood, you're going to lose the child very quickly because all the blood's going to go out. You can't see anything if the heart is full of blood. So to help us to do those things, to not require heart to do the function so that the rest of the organs get good oxygenated blood supply. At the same time, we have a bloodless field within the heart for us to do the surgery. We have this machine called the heart-lung bypass machine, or commonly called the bypass machine. It's got two components. It's got a pump, which pumps blood under high pressure to the rest of the body, and it's got an oxygenator, which does the job of a lung, which takes away the carbon dioxide from the blood and puts in oxygen into the blood. But for this machine to work, we need to give a drug called heparin, which makes the blood thin. Because as you know, if I have a cut in my hand, the blood clots. Same thing will happen if you put the blood through any artificial tubing. So to stop that from happening, we need to give this drug called heparin, which stops the blood from clotting completely. So it goes down to the machine. So we put in big pipes into the right side of the heart. So drain all the blood coming into the heart through this pipe. It goes to the machine. The machine spins under high pressure, puts it through this oxygenator. The oxygenator takes away the carbon dioxide, puts in oxygen, and comes back. We put another big pipe in the aorta, which is a big artery which comes out from the heart, so that the aorta then carries all the oxygenated blood, provides oxygen and nutrients to the rest of the body. So we can isolate the heart and the lungs from the rest of the body, and we can do what we need to do by opening the chambers of the heart, fixing whatever we need to fix. So that bypass machine effectively takes over heart and the lungs during the duration of the surgery. So that's a very special machine. It pretty much costs same as buying a house. So it's a pretty sophisticated, pricey machine, which is run by people called perfusionists. Perfusion is a Latin word which means to provide. So perfusionists are the ones who provides blood and oxygen to the patient. So these perfusionists are people who've had background in health science, and then they do a 3-year hands-on training and theoretical training in running these heart-lung bypass machines. So they are the experts in doing this. So they do this under the supervision of the anesthetists and the surgeons. So effectively, they hold the child's life for that duration of the surgery. So they're responsible for making sure the child is alive. So pretty impressive and unique skill set for these people. And they have constant monitoring of various parameters. So they constantly keep looking at what is the level of oxygen in the blood, what's the level of carbon dioxide in the blood, how much of lactate, which is the bad stuff that comes from the tissue, how high or how low it is, what is the level of sodium, potassium, calcium, the whole lot. They have a very, very tight control of these things. And they can also put in fluid if needed, or take away fluid if needed. So they are pretty integral in conduct of our heart surgery.
Yeah, indeed. And I suppose it speaks to what you said earlier, like it's a very big, vast team that are very specialized in getting us to this point of you actually going into that little strawberry and fixing and repairing. You need all your team on, obviously with years of training and experience to do that. So to lead on from that, the heart-lung bypass, like you said, you've had to go in to the newborn or child. So obviously when they're young, Prem, I can speak from experience with my son. He was 6 months old when I placed him on that bed in theatre. How is that different to then operating on, say, a 5, 6, 7-year-old? Because obviously that conversation would have been between myself and my husband and you as a surgeon. What is it like when we've got a child that's a lot more aware and it's a quite intense surgery? You're opening up their chest. How do you go about it as they're older?
I liken this to bringing up children. I'm a dad too. So when you have a newborn child, you're overwhelmed with it and you think, oh my God, when they get to 2 years old, it'll be easy. When they get to 5-year-old, it'll be easier. When they get to 10-year-old, it's going to be lots easier too. And when they get to 10 years old, you realize, oh no, you've just exchanged one set of challenge to another.
No.
And that's all that's happened. You just shifted one set of challenge to another one. It's not got any easier. And cardiac surgery, in some ways, is similar. Newborn children have unique set of challenges. They've got unique physiology because the organs are still not matured yet. They're still going through the growth phases. And that's the challenge. Whilst in an older child, 5, 6, or 7 years old, the organs are a bit more matured and they're bigger, so the margins are better. So you're not talking about 1 or 2 millimeter vessels, you're talking about 10, 12, 15 millimeter vessel. So your margin for doing things are better. They have lots more reserve than a young child, and the technical ability is different. You're facing a different technical challenge to a newborn child. That's from the purely technical aspects. But from more social aspects, there are two elements to it. We are not just treating the child, we are also dealing with two adult individuals who are invested in this child, who are emotionally as much stressed
Absolutely.
as anybody else. So we see that our duty is not just to look after the child, but also to look after these parents. When you have a newborn child, it's a bit tricky because they still don't have that great amount of bonding. You tell them what it is. They've not made memories yet. They don't have birthday parties to think about. They don't think about he did this or she did this when she was 1 year old and she did this when she was 2 years old. She went for this party. We went to this theme park. So there's lots of memories and stuff like that when it comes in. So it's a bit more challenging for families when they have to subject their 5-year-old or 10-year-old child to a surgery than a newborn child in some ways. And also, we also have to consider the emotional aspect of treating these 5-year-old and 10-year-old children because they have developed their own unique characters. They've developed their own unique likings and dislikes, and we'll have to respect that too. And we have to make sure the experience they have through cardiac surgery does not become a scar, as a bad experience for their lifetime, to make it as pleasant as possible to the extent that we can. So, yeah, we're exchanging one set of challenge with another.
Yes, indeed. Indeed, you are. And you were right with your analogy. Exactly. You think to yourself, that's all right. When they start walking, it will be fine. When they start running, when they can start at school. And I suppose, that then, like you just said, it's not just about the actual technical side of things. I love that you started talking about the social and the emotional side, because I suppose when you then come back in after surgery is completed, you're not just having the conversation with the parents, you also have to make sure that you engage with the child.
Yes, and they are individuals and they have their own preferences, their own likes and dislikes, and we have to respect them for that and treat them for what they are.
Yeah, that's it. And with that, Prem, obviously for the first time for parents going in to see their child in ICU, as I said, again, lived experience here, I'll never forget waiting for yourself, as in like a surgeon, to call to say it was successful, and then to walk into ICU. What's some advice that you can give people and parents and caregivers for what they're going to see? I know it's a big question, Prem, but yeah, how do you prepare?
There are a few coping mechanisms that I have, which I tell them because, I had my daughter going through some minor surgery. I think it's interesting when you're on the other side of the fence, you're not the caregiver anymore, what you're waiting for somebody else to do. So that has opened up a few things for me, which has held me in good stead when I talk to the families. As surgeons, when somebody asks me how long the surgery is going to take, all I'm thinking about is when I've started to do the surgery to when I'm finished. But that's not the question the family is asking me. The family is asking me, when I say bye-bye to my child, when am I going to see the child next? That is the duration of surgery for them. It took me a while to realize that, because I'm thinking,
that's so true.
It's only 2 hours. But then 4 hours later, the baby is still not back in ICU, and they're thinking, but he said 2 hours, it's 2.5 hours now, 3 hours now, 3.5 hours now. What's happening? And for us, it's not tweaked because the child is still going through the planned pathway. So now I tend to tell them, look, what I do takes about 2.5 hours, but as far as you're concerned, from the time you say bye to us calling you back in ICU will be 4 hours or 5 hours. So that includes everything from the monitoring to be put in, the child to be anesthetized, and all the tubes to be put in. And after we finish, make sure everything is stable, to shift the child to the bed and then come back to ICU. So that's the time that takes for you to know how long it takes. 1. 2, I keep telling them, look, I can tell you how it looks. There'll be lots of pipes and drains and everything, lots of tubes, more than what you can imagine. It will be daunting. It will be really stressful to see, but remember, there are hundreds of people who have gone through this before, and they're fine, and it'll be fine. It'll be daunting, but it's okay. It's still your child. one of the things that I find is parents think that they can't touch the child after surgery. Oh, it's had a surgery, I can't touch the child, I can't hold my child. No, it's still your child. Feel free to hold your child. It's fine. How much ever you reassure them, it's one of the most daunting things for you to see as a parent, to come into ICU, see a child with all these bandages and tubes and pipes and drains. But it's one of those necessary things that they have to do to make them get better.
Yeah. And Prem, I'm actually a bit emotional, even you just talking through that just then. The memory takes me right back. So I'm just going to gather myself. But after that moment, so that people understand, because it is such a big multidisciplinary team, how much are we then involved with you after the surgery? So obviously, because like you said, there's this big team that gets them to this point. And so then there's another handover, isn't there? So
yeah, there is.
How long am I going to be around you before I'm handed over to the cardiologist on the ward?
I tend to get more involved than probably what I should. If you ask my intensive care colleagues, they shoo me away from ICU saying, no, you can go away now. It is a big team and each one works to their expertise. And then we respect each one's expertise. They are there because they are the experts in what they do. And there's a very good handover process. And because it's a small team, each one of us know each other at a very individual level. And we as surgeons, we have an emotional bond with the child and the family. We think because we've operated on them, there's a bond which can never be broken. And until the child is well and has gone home, they're going to be sick of seeing us every day.
So when Prem's not in surgery, you're on the wards, you're lurking around the wards, are you? Going in and out, checking on all of those children you've operated on.
Each one of us have our own quirks. For example, what I do is the first thing I do when I come to the hospital is go to ICU, make sure everyone's fine from the previous day. Then we go do our ward rounds. Then we come back to formal ICU ward round. And then I come up to the office to catch up with all the administrative stuff. Before I go to theatre, then I'll go to ICU, make sure they're all fine. Then I go to theatre, finish the surgery, then come straight back to ICU, walk around, make sure they're all fine. Then I go up to the office. And when the child comes to ICU, then come down to ICU, talk to the family from who have operated on, then have a quick walk around to make sure the other kids are fine. Then go up to the office, do whatever I need to do. When the second child is ready for surgery, go to ICU, do a quick walk around, then go to theatre, finish the surgery, come back to ICU, do a quick round. And then when the second child comes to ICU, do a quick walk around. And then before you go home, do another quick walk around and then go home. I'm sure every surgeon has a quirk like that. They're always, all roads to theatre leads through ICU.
I was about to say, I now understand your reference earlier that ICU want you to move on now.
Yes.
Sounds like you spend more time in ICU than you actually do in theatre, which is wonderful. So, Prem, I'd love to know a bit more about, obviously, the extra work that you do. I know that in 2022, you travelled overseas to provide surgical services for a UK-based charity. So can you tell me about that?
Well, I'm part of this charity called Healing Little Hearts, which is run from UK and Leicester. To start off with us, some of them were trained abroad and then went to UK, and this was our way of giving back to our communities and communities which are less well off than UK or Australia for that matter. So what we do is we're a group of surgeons and intensivists and anesthetists and ICU nurses and ICU doctors who make a team, and we identify centers who are in need of expertise. We go there, depending on what it is, we go there, operate on children, educate the local team, make them more sustainable. And I see is my way of giving back to India. Because I trained in India, and the only way I can give back to India is through what I've gained. So that's my way of giving back to India what I gained from India. So I try and do 3 trips a year, and it's a great experience because we get teams from all over the world. So I was in Bangalore in the last week of April, so 3 weeks ago now. So we had a team, we had intensivists coming from Brisbane, we had ICU nurses coming from Brompton and London, we had the anesthetists coming from Middle East, we had the cardiologists coming from Liverpool, and we had the perfusionists coming from Liverpool and the local team in India. So it's a great experience to learn from others, at the same time help the local team to build their expertise so that they can help more and more children. So I see this as an opportunity, not just going and operating, but as an opportunity to have sustainable programs so that it carries on further out even after we've come back. So I do 3 trips a year, and it's a great team building exercise too. So if I go out with my team in ICU, the bonds that we make are unbreakable. Your whole working relationship becomes different. And the volume we do is quite high. We churn out quite a lot. In Bangalore, we did 21 cases of fairly complex cases in 5 days, which is like 4 to 5 cases.
Wow. To put that into perspective, how many cases do you do a day in Australia?
We do about 2 a day on an average in Australia.
Wow. And you're doing 4 to 5 over there.
Yeah, and the whole working model is different. There are no fixed roles. Everyone does everything else. So I'll be pretending to be an anesthetic assistant for the anesthetist, and the intensives will be coming into theatre to give us a hand, and the perfusionist will be by the bedside looking after the child. So everybody does everything to get a very good outcome. So what it does is it forms a huge bond amongst the team. And that can only be a good thing when we come back home to carry on doing what we do.
Yeah. It is. It's like you said before, even just your surgery that you perform on your child. Like you said, it's unbreakable.
Yeah.
Yeah, that's beautiful. And this is not only just, you don't just do this. You don't just go over to Healing Little Hearts. I also I know a little bit about the telehealth project, bridging the gap with the cardiac support in North Queensland. This is where, Prem, I have to let you know that I'm actually a Queenslander.
Okay.
So
good.
I get very excited. Yeah. So this for me, I love the fact, and I live now in South Australia and we lived regional for a while. So to think that you're up there in my mother country and helping bridging the gap. So talk to me about this, because it sounds like an amazing initiative.
Yeah, look, Australia's got unique challenges and unique geography. We've got population centers which are quite wide apart. And because we don't have big population, we can't have cardiac surgical centers everywhere. So we have surgical centers in most of the capital cities. But I'm quite aware that the regional population should not be disadvantaged because of that. Yes, the reality is you can only have surgery in Brisbane, but that does not mean that we have to disadvantage the regional families because the surgery only happens in Brisbane. We are trying to harness the technology to our advantage. So one of the things that we started is the Queensland Congenital and Heart Network, which is a network of people who provide care for these children right across the state. So we've got few people across in Gold Coast, Sunshine Coast, Townsville and Cairns who also provide care, but not necessarily surgery. So we've tried to have a hub and spoke model where the hub is sitting in Brisbane, but we have spokes in these regional areas who can do most of the work up there. So the only reason why they would come for Brisbane is for surgery, and surgery alone. Everything will be closer home. But if I have to tell somebody, oh, you're going to go to Brisbane, I'm going to meet Prem and he's going to do the surgery, it's a very daunting thing. So what we thought is we will reach out to them. So one of our nurse consultant who is very passionate about this. So what we do is we do telehealth. We use Teams or Zoom or whatever that works for them. So they can have a face to the name. So we'll say, look, we are the surgical team. Your cardiologist thinks you need surgery. This is the surgery you'll need. This is the team that you'll meet when you come to Brisbane. These are our contact details. And not just talk to the family. In some of the indigenous cultures, I'm sure you're aware, it's an extended family which is involved. It's not just a nuclear family. So they all can't come to Brisbane, but they are all emotionally attached to the fact that one member of their mob is coming here for having something major done. So we talk to the whole thing. So they come to a regional health center where the regional health worker facilitates this. So all of them can see whom they're going to go to. And this is the team that's going to help the child get better. So that automatically reduces the stress level. And when they come to Brisbane, then they look at a familiar face. We think that makes a big difference. And we've had very good feedback as to what a difference it made from the fear of unknown to, I know I'm going to Brisbane. I know I'm going to meet this person. I've already met this person and this person's going to help me.
That's amazing, Prem. It really is. And like you said, I'm quite familiar with obviously being down here in South Australia. We've got APY lands and a lot of understanding about RHD, and same, our cardiologists go up with, Gavin and Bo go into these communities, because exactly what you were saying, it's huge for them. It's huge for them. And, medical help is not like, we're so privileged. We can just pop down the road, in these remote communities. And like you said, it doesn't just affect one, it affects the family. So, Prem, behind this initiative, did COVID play a part in this? Or is this something that you and the team were thinking about prior to COVID? But I suppose the thing that COVID did was sort of push us to really lean on that technology.
Yes, we always wanted to do this, but COVID really helped because people then started making this as the norm. It was not something unique, and it's not something which was formidable. It became okay to be communicating with people through Zoom and Teams and things like that. So there has to be something positive out of COVID, isn't it?
Absolutely, Prem. And yeah, I concur. There's a lot of things we can talk about with COVID that aren't so positive, but I do think leaning into the technology and telehealth, let's face it, telehealth has always been there, has it not? It's just that we haven't actually embraced it. And I love that pilot. So I hear it's piloted till the end of this year. Is that correct?
Yes, it is. And we are hoping that we'll get some sustainable funding to keep it going, because the initial feedback we've got have been exceptionally positive.
And I'm sure, like you chatted about earlier, obviously, like you said, there's a lot of technical training that you guys and the team go through many, many years to be a consultant, fellowships, surgery. But there's also too, like you said, there's that social and emotional side of things that we need to be really aware of. And like you said, you're obviously getting a lovely technical outcome of the surgery. But if you can bridge that gap of having that emotional and social connection early on in the piece, the stress and anxiety in that person's body, surely that has some sort of medical outcome.
It definitely does. And we're all very aware when we meet the families, we're not looking at people in their normal self. They're really stressed to their eyeballs. And sometimes, having had this ability to talk before the actual thing comes on makes a big difference. They're a bit more reassured, they're a bit more relaxed. And that can only translate well to their children, because we translate our emotions to our kids consciously as subconsciously. Kids are smart. They pick up if their mom or dad are stressed, they pick that up and know that there's something wrong. There's something not normal here. And that cannot be a good thing.
Yeah, that's that co-regulation, isn't it? So, Prem, obviously we've covered quite a bit, and I'm so mindful that I'm taking you away from your probably next round in ICU before you go home. Now that you've let me know a bit of your quirk, now I know that realistically you want to be down in there checking on your babies and your patients. But can you tell me just something before we wrap up about what's something that's happening in the advancements of cardiac surgery that you're really excited about?
One of the things I'm really excited about is we have what is called the fast track program. Traditionally, what used to happen after cardiac surgery, they would come to ICU, they'd be in ICU on a breathing machine overnight. So by default, they stayed in ICU overnight, and they would come off the breathing machine the next day, stay in ICU for one more day, and then, if possible, go to the ward. We start looking at how can we involve families more, make this a more pleasant experience for not just the children alone, for the families too, at the same time not compromise on safety. So we started doing what's called a fast track program, where we pre-identify patients whom we know how they're going to behave post-operatively. So we do surgery on them. They come to ICU. They stay in ICU for less than 4 hours. The breathing machine gets pulled out either in theater or as soon as they come to ICU. After 4 hours, they go to the ward, and we encourage the family to be with the children overnight. And then they become part of looking after their own children. You can't have a better person to look after the children other than their own parents. So they become part of looking after the children. So they go through the whole thing with them. So they're not in a very alien environment of lots of lights and sound and flashy stuff, with a child being on a breathing machine, to child being more normal, able to communicate with their families, and the family able to be with them when they need them and help them when they need them. That's made a big difference to the whole experience of the family and the children doing surgery. So we've done about We started this about 2 years ago. We've done about 110 now, and we've had very good outcomes. And the hospital stays come down. Obviously, stay in ICU has come down. The morbidities associated with staying in ICU has come right down. And the experience for the family is always, without exception, has been positive.
I'm actually trying to find the words how I feel just even hearing that, because sometimes we focus on those technical advancements, don't we? And what you're really talking about is that really patient-centered care and that holistic care and that touch of their parents, their loved ones in that healing journey. It's so powerful. It's so very powerful. I'm certain the outcomes, obviously, there's an economic outcome as well, isn't there? There's benefit for the hospital financially, which then obviously then takes pressure off our overall health system, which is not something to be sneezed at. But I love the fact that it's actually just involving us all in the care process. It doesn't always have to be something, an advancement in something mechanical.
Yeah, look, I don't want to bore you with all the technical advancements that we are making. We are constantly trying to do new stuff. But I think what's more important is this human touch to what we do, because we are not just fixing the hearts. We are actually taking on the responsibility of the whole family unit and making sure they are looked after.
That is so beautiful, Prem. And I'd actually just love to leave just on that note, because I think that's just so powerful in itself. But thank you so, so, so very much for your time, for your dedication to cardiac surgery, the Heart Kids community, everyone, the fact that you're passing on that knowledge to your mother country, your home country, you're bridging the gap with our Indigenous community. I actually can't, there's just so much, Prem, but all I can say is thank you. Thank you from the bottom of my heart.
All I can say is thank you for giving me this opportunity to talk to you. It was amazing to talk to one of moms who had gone through what most of our children go through, and you can understand what it feels like to be to somebody who looks after a child with heart disease.
Thank you, Prem.
Thank you.
Sometimes this podcast talks about some heavy things. If this brings up anything for you or someone you love, it is important to reach out for support. The Heart Kids Helpline provides support and guidance for anyone impacted by CHD. You can call the helpline on 1800 432 785. To access more information about CHD, as well as support from Heart Kids, visit the website at heartkids.org.au. The information on this podcast is not a substitute for medical advice from your doctor or healthcare team. Always talk to your doctor about matters that affect you or your family's health.